Welcome to another episode of the Being and Doing podcast, where I try to create a space for and bring you the stories of the unique minds that are all around us. I'm very excited about my guest today because I'm certain that his story will challenge, inspire, and stimulate your being. So today I'm speaking with Dr. Ben Sessa, and I want to share with you two impressions about him. One of them is that Dr. Sessa is the first person in the UK that has legally been given the psychedelic compound LSD. And the other one is that when I met Dr. Sessa for the first time in his lecture, I found him to be a person of great integrity and rigor, yet extremely approachable and kind. And after reading his book and understanding the breadth of his experience, I'm actually even more curious to know his story, and I hope you will be too. So welcome, Dr. Sessa.
Hello, welcome. Thank you very much, Alexandra. It's a great pleasure to be here.
So I will start to actually explore this really incredible experience of yours. And I will just ask you, what are actually some words that you identify yourself with? Because you have so many different roles.
The words I identify with, primarily, I'm a medical doctor who specializes in mental health, and in particular, child and adolescent mental health. And I'm also at the forefront of psychedelic research, looking at drugs such as LSD, DMT, ketamine, Mdma, Psilocybin, as treatments for mental disorders. And for the last 15 years, I've been involved in research with all of those compounds, writing editorials, carrying out original research. And now I am the Chief Medical Officer of Awaken Life Sciences, which is a new biotech company specializing in the research, development, and delivery of psychedelic compounds for the mass population. So I've got various different hats that I wear. I'm also a cannabis prescriber, one of the first cannabis prescribers in psychiatry in the UK. And I do a lot of activism work around drug policy reform. And I'm the co-founder of a group called Breaking Convention, which is a conference, an annual conference in the UK, biannual conference in the UK. So lots of different things that I do. And I also play the guitar and sing in a great band called Delta 9.
Oh, wow. This is incredible. So I would start maybe by your formative years, and then we can come to how did you get to wear all these hats. So I read in your book that you are the only doctor in the family of teachers. So how did that come to be?
Yeah, all of my family, my parents, my siblings, I'm the youngest of 6, were very much in the arts or education. So artists, writers, musicians, and teachers. And I grew up in that kind of very liberal household. My older siblings, because I was the youngest of 6 and I was born in 1972, my older siblings were kind of real sort of hippies in the 60s era, which obviously passed me by. I grew up in the 70s and then was a young person in the 80s and late 80s and into the 90s. So the rave scene was much more my style by the time I was that age. But I was always surrounded at home by literature and art and philosophy and discussion. We didn't have a TV that we watched. We had people made things and created things and performed and wrote with one another. So it was a very liberal kind of hippie-like household in a way. So I'd had kind of quite an exposure to that kind of lifestyle as a child. But also the whole family were very academic. So one brother went to Cambridge and sister went to Cambridge. Everyone went to university, but mostly studying the arts. I was the first person to do science of any kind, and certainly the first medic.
And then how did you choose to be a doctor, basically? What was there a personal drive there, or was that something that you were suggested by someone?
I had a very serious accident and almost died when I was 15 years old. I fell off a mountain and broke both my legs. I lay on the rock face for 3 hours before a helicopter came and picked me up, took me to hospital, spent many months in hospital and then a year in a wheelchair and then on sticks for a year. I was told I wouldn't walk without a stick. So I'd really badly destroyed both my legs. And this kind of happening right in the middle of my adolescence was a kind of interesting experience. But I saw so much of hospitals during that time. I kind of vowed to be a doctor, and I wanted to be the world's first nice doctor, because I had this experience of, you know, feeling pain, and thought this is something I'd like to do, but to be the world's first kind doctor that doesn't hurt children, which is a crazy idea of looking at it, because they were all excellent. But yeah, that's what kind of drove me in to do medicine. Because at school I was equally good at the arts and the sciences, and I played lots of music and did a lot of art at school. So kind of had a crossroads when I had to decide, and I decided I would do science and medicine, and was very fortunate to get into UCL Medical School, and then took a year out traveling, went all around the world for about 8 months, backpacking with 2 friends, and then on to university, medical school in London, UCL.
Oh, wow. So you had a fair share of trauma in your life, and you are supporting people with trauma now, actually. This is incredible.
Well, I had a fair share. Well, that was my only incident of trauma, and it was physical trauma. But surrounded always by the most warm, deep, loving, secure family, big family. So grew up in a very, I would say it was a very idyllic childhood, despite that near-death experience as a teenager.
And so you said being the world first kind doctor, and I actually quite like this, because often it's not even about kindness. It's also understanding the people's psyche when we are treating them. So it's your job as a psychiatrist, but I'm wondering how much of that you see in the medical profession, that people are interested in that part of healing. And I know that's not the word you really like.
I think nobody goes into medicine without a desire to heal. It's very, very hard work, medicine, physically and obviously intellectually, and the time and the commitment. I don't think anyone would go into medicine who wasn't a kind and compassionate person who wants to see patients get better. If you did go into it without that, if you went into it just because you liked the status of it, or you liked even just the science of it, I think you would get burned out pretty quickly, because you cannot do your job as a doctor unless you are genuinely compassionate and caring, and an advocate for your patient, a staunch advocate for your patient, and are prepared to work fastidiously for their betterment. So you see doctors that burn out when they lose that focus, and then the job becomes incredibly difficult to do. So you have to hold on to that compassion and that sense that you're there to improve people's lives at your own expense sometimes.
And I'm wondering, you're doing a very courageous move and brave, basically battling the legislation of psychedelic drugs in the UK. And I'm curious about that part of your journey, trying to understand, what do you do when you're really frustrated and don't feel you will be heard or understood?
Well, that's a really good question. And it's interesting. Just yesterday, I had a session with a media trainer, training me to talk to the media in crisis situations. If you're on the news and you're having to defend a patient who's complaining, and you've got the lawyers and the solicitors after you, how do you deal with this? And she said I did very well, but she said, Ben, I detect a sense of anger in you, and a sense of anger and defensiveness in some of your questions when you're arguing with other professionals about psychedelics. And she said, she was there to train me as to how best to communicate with the media. She said, you need to do something about that. We need to find a way to make that work, because the media will tear you apart if you're like that. But the reason I'm saying that is it's interesting that you asked that question now, because I'm a really gentle, sensitive, kind, pacifist, non-conflict sort of person. But you know what? I do get angry. The thing that makes me angry is the frustration at 15 years working with psychedelics, and I know they are the right thing for my patient. I know they are the cure that the patients are looking for, that my patients deserve. Yet I'm at loggerheads with the jurisdiction and the rules and the narratives that come down from very poor policies in terms of drug management, which is a impediment to this important research and medical potential. So I have to try and not get angry, because anger is a terrible, awful emotion that never solves anything. But I think frustration is a better word, impotence even, that as a scientist, my world is one of evidence base and what works and what's safe and what is efficacious. So it's very frustrating when you then hit a political wall, and you have to work with restrictions that have been imposed by people who are not doctors or neuropsychopharmacologists or understanding of the science, yet they are able to restrict medical research. And so that is very frustrating. But I guess we just have to continue slowly gathering the data and evidence, demonstrating the safety and efficacy, and working with the media to demystify psychedelics, normalize psychedelics, and demonstrate their safety and efficacy. And then there's no reason why the rules won't change, because they have to change. They clearly will change, whether it's today, tomorrow, in 5 years or 20 years. The restrictions around compounds and substances, both recreationally and for research, will all be lifted. There's no question of it. The war on drugs is unwinnable and unethical and unpoliceable and dangerous, and kills young people and creates the mafia and funds criminals and destroys societies and costs billions and doesn't work. And it's so plain to see all of that now. And slowly all over the world, more and more creative and scientifically led governments are starting to realize this, and restrictions are changing, and people are getting better as a result. It's very sad that we happen to live in one of the worst countries in Europe for this. I think our drug laws are second only to Lithuania and Romania, I think I heard, in terms of just how harsh they are, which is extraordinary, because we're here in the UK, we're quite a forward-thinking, liberal, we like to think, leading edge country. But when it comes to our drug laws, we're stuck somewhere in between 1954 and 1958. It's absolutely outrageous. Yeah, a lot of work has to happen, and I'm really pleased to be at the forefront of that. But it is an area that makes me very frustrated. It's certainly true.
Yeah, I mean, I can actually hear the conviction in your voice, and I think it's a conviction of a person who sees the data. So I think when we talk about psychedelics, we can obviously talk about them in many different planes, but I would like to start from the human aspect, because you are actually directly in touch with patients, and I would like to hear from you, how does it look when you see a patient which has just hit this barrier, and you know that the psychedelic is the only thing that can help? And I'm just wondering if you can just give a flavor to people of how does this barrier for a patient that is really struggling look like in their everyday lives?
Okay, so I mean, I think the full answer to this question is to understand the concept of attachment relationship and the vital role that has in human development of psyche, and the vital role that the outcome of that has in the resilience or vulnerability to mental disorder. I often make the fairly bold statement that most, if not many, if not all, long-term mental health disorders are due to psychological trauma in childhood. Now, that is not an entirely accurate statement, and people can get mental disorders having had a lovely childhood. That does happen. When those sorts of people tend to do very well and respond to all the treatments and attend all their appointments diligently and get better. But for the vast majority of people with long-term mental health disorders, underlying it all is a history of a poor childhood. Now, we can talk about big T trauma, things like physical abuse and sexual abuse. But I think we mustn't take our eye off the ball when it comes to what we could call small T trauma. So some of my patients will have had a very clear history of childhood homes, children's homes, foster homes, institutions, physical abuse, sexual abuse, very, very social services on the radar type history. But many of them who are equally as unwell with whatever psychiatric diagnosis won't have had that. But when you ask them about their childhood, they'll say, I never felt loved. I never felt wanted. My parents put me down. My parents humiliated me. I couldn't get away from home quick enough. They were cold, they were critical. So all of those aspects of what we might call emotional abuse or neglect, don't take your eye off the ball of those. They are equally traumatizing. Indeed, it's arguable that they're more traumatizing because they're so chronic. So a child who has a single episode of physical abuse or sexual abuse in childhood will probably fare better in life than the child who doesn't have any physical or sexual abuse, but has that constant daytime drip, drip, drip. I don't love you. Your dad doesn't love you. We didn't want a girl. We wanted a boy. You're unlovable. You're stupid. You're ugly. You're never going to amount to anything. That kind of abuse is hugely damaging to the development of psyche. Now, it's all about the attachment relationship. And the attachment relationship, as you know, is this beautiful reciprocal dance that goes on between the primary caregiver and the preverbal child, infant. And the primary aspect of it is modeling and responsive to a reciprocal responsiveness to that pair and their behavior. And as a result, you build up networks and pathways in the brain, and you build up narratives. And if you're lucky enough to be a child who was played with and praised and told they were beautiful and lovely and clever and they're going to do well, then you build up this personal narrative of yourself. I am good, I am worthy, I'm going to succeed, etc. And a narrative about the world. People are good, people can be trusted, most people will help me, I don't need to hurt people. Now, if you were brought up in an environment from the day go, in fact, even before day go, even before birth, because there's evidence about prenatal stress on developing fetuses, and all you've ever known is pain, fear, abuse, humiliation, neglect, then you build up a very different picture of yourself and the world. I'm useless. I'm a failure. I'm not worth it. It's my fault. I'm a slut. I deserve to be exploited. I did this to myself. And the world, people are dangerous. No one's to be trusted, etc. It's okay to lie. It's okay to cheat. It's okay to steal. It's okay to drop litter. It's okay to hit people. You know, it's these things we learn when we're very, very young. And this is the greatest predictor for later adult mental health problems than anything else, is childhood trauma of some kind. And then once the personality forms and you go into your adolescence and then into your adult life, you carry these narratives. So even when you've left that childhood environment of fear and you're a young person or an adult going out into the world, your brain is still in a hangover mode that these narratives are true. And it's arguable that those kinds of narratives, and even the negative ones, even like that result from complex PTSD, or you could argue that PTSD is almost the sign of a healthy brain. It's a positive neuroadaptive response. You have survived your childhood by developing in that way. You would not have survived your childhood if you trusted people and thought the world was safe. Instead, your brain physically grows in terms of its network and its connectivity in such a way that it's a survival technique to be scared. And then you go into the adult world and those assailants are no longer there. You're living in a benign community, but your brain still has hangover. And so when it comes to trying to form intimate relationships with others and develop relationships at work and with your friends or your partner, you feel attacked, you feel humiliated, you cannot trust people who compliment you. Instead, you are suspicious and insecure, and this is damaging to these relationships. Now, in the worst cases, this results in severe mental health problems of all kinds. But it may be much more subtle than that. It may just be failed relationships, difficulty holding down a boyfriend or a girlfriend, always feeling insecure, not being able to sustain or buffer criticism, because it triggers in you these reminders of much more serious attacks that took place as a child. But these are played out as kind of role play games in intimate relationships. And it's very impairing of a healthy psychological life. Now, when it comes to psychological or psychiatric categorical diagnoses, I'm not a big fan of these. I think it's all about the core issue of this early trauma. And as we said, different levels of abuse and trauma, but they can all be equally as damaging. The overlying phenotypes, depression, anxiety, eating disorders, personality disorders, addictions, it doesn't really matter which one of those you're going to get. You're going to get one of them at some point in your life if you've had that early trauma, or you may get one or two or three or four of them at different times in your life. So I think in psychiatry, we have too much emphasis on the end phenotype disorder, and we treat that, forgetting the underlying cause, which is the trauma. And it's irrelevant what the surface presentation is. And so I don't know if that answers your question about really I'm trying to really emphasize the importance of attachment, the importance of early years, because that attachment style that you develop becomes a very rigid blueprint for how you then go on as an adult. Some of the core fundamental parts of psychological functioning are formed in those early years, and it's very difficult to shake them.
Yeah, I mean, I can only testify to this from my own experiences as well. But I read yesterday actually that it's not only what you got in childhood, it's a lot about what you did not get. And this is a bit more difficult to remember because you have never gotten it. And actually, I loved about your lecture mentioning that when we look at children and we see them being abused, we have much more compassion than when we look at a teenager or even adult that has gone through the same experience, but we forget to see that abused child. And you are probably seeing that mostly every day in your practice. So I want to actually touch this also in relation to the legislation and everything we are talking about.
Yeah, I mean, it's quite right that as a society, we have this gushing sentimentality for these little childhood victims. And we have, TV shows like Children in Need, where we throw money at our television sets for these, poor little abused children. What happens to that little 4, 5, 6-year-old as they become 11, 12, 13? The hoodie goes on, they start smoking weed, they start nicking mopeds, and then by the time they're 18, they're using amphetamine and then crack cocaine and then alcohol and then heroin. And suddenly they become this public enemy number one. They're completely denigrated and demonized by society. Whereas 10 years earlier, we had all this emphasis, we had all this sentiment for them and empathy. And it's like society just switches off their empathy switch and forgets the developmental roots of why people behave like this. If you ever meet a person, an adult, who you think is rude, arrogant, aggressive, narcissistic, and unpleasant, say to them, what happened to you? Because only hurt people hurt. And it's so easy to just look at the surface presentation. But at the end of the day, if you meet a person who is rude, aggressive, greedy, unpleasant, and all of those things, take them aside and say, I'm really sorry that you had a difficult childhood and were bullied by someone. Do you want to talk about that? Now, I'm not suggesting people should go out and do that, but as an exercise, you'll probably find they were humiliated at some point. So it's being a doctor is about being empathic, because you work fastidiously as an advocate for the patient before you, with no judgment or criticism. But in psychotherapy, you need to get to that essential core in order to do the work, because until the patient, these external behaviors of narcissism or aggression or anger or greed or arrogance, these are protective defense mechanisms that the patient, the person is using to get through life, because it's so intolerable to live in their brain. And so they develop these defense mechanisms, which are maladaptive. So whilst those defense mechanisms were adaptive as a baby or as a young child, you know, they had to learn to cheat and steal and lie because no one was feeding them. No one was caring for them. If they didn't cheat, steal and lie, they were going to die. But they survived their childhood by developing these behavioral approaches. But those become, and that's great, they get through their childhood, but then they get into the big wide world and it's not that noxious. The world is actually very benign. Most people everywhere are completely lovely. Almost everyone is kind and charitable. We know society works like that. Society wouldn't work if we didn't all predominantly have good attachment relationships. And I think people forget that, you know, what the law and order that we have in place is not being imposed by some fascist state police. You take a town of 20,000 people, there's probably only 3 police officers on duty of an evening, or maybe say 3 or 4, 2 of which have to stay in the station to look after the custody suite and with a sergeant. So you got two policemen on the beat for a town of 20,000 people. Why is it everyone not out robbing, raping, stealing, beating each other up? Well, the reason they're not is because they don't want to. The world is very benign and we forget that. And the media presents this picture of, you know, death and destruction. We are predominantly really safe. But if you've been a person who's experienced this pain and fear, you still have this hangover that it's not. And it's hugely impairing for forming relationships and maintaining relationships. So in some ways, the whole of the work of psychiatry could almost be completely dissolved. We could empty the prisons, half empty the prisons and the hospitals overnight if we just had better care for single mothers of children under 5. In time, we would develop a whole population of people with positive, secure attachments, and that would massively improve society and reduce mental disorder.
Oh, wow. There are so many things I want to unpack here, but I'll start with getting to the core wounds of people and all these masks and defenses that we are building in order to protect ourselves and survive. And I'm wondering now, coming to the psychedelics and their role in helping us break those barriers, how do they do that?
So once you've got this adult who has had this trauma and then has this head full of narratives that are fairly rigid and fixed, and it's difficult to shift them, and then going back, they've, as a result, have developed some kind of mental disorder, doesn't matter which one, eating disorders, personality disorders, addiction, depression, anxiety disorder. A big barrier to them moving forward is inability to engage in psychotherapy and actually do the work on the trauma issues. So we have to date this top-down biological model of medical psychiatry, which is to give maintenance drugs such as SSRIs, mood stabilizers, hypnotics, etc. And we give them these drugs to treat the symptoms of their overlying disorder. So you have a patient with a head full of trauma that they've never addressed. They're presenting as an alcoholic or a heroin addict or PTSD or whatever. And they're a little bit depressed. We'll put them on an antidepressant. Doesn't cure the problem, but takes the edge off their mood. Then next week they come in, they can't sleep. Okay, you put them on a hypnotic, like a sleeping tablet. Doesn't cure the reason why they can't sleep, but it helps them sleep. Next week they come in and they're hypervigilant, they're on edge. And they're so on edge that they're actually feeling a little bit paranoid. Okay, we'll put them on an antipsychotic. Not going to cure the reason why they're feeling on edge, but it's going to take the edge off the psychosis that's emerging. The next week they come in and their mood is going up and down and up and down. So we put them on a mood stabilizer. So here we are. We've got them on 4 completely different classes of drugs to treat the overlying symptoms of this disorder, which is rooted in trauma. Now, you're only going to cure this patient, and we can come back to the cure word because it's very important. You're only going to cure this patient when they can sit down in a trusting relationship with a therapist who can talk about that night when they were 10 years old and their grandfather came into their bedroom. And until they do that, they're not going to get better. They're going to use all kinds of defense mechanisms, substance use, self-harm, promiscuous sex, violence, physical health manifestations, bad backs, painful hips, every kind of illness you can get, eating issues. And all of this, they're all smoke screens. They're all avoidant behavior. And indeed, taking the psychiatric medications are also a smoke screen and an avoidant behavior. And you try and get them into psychotherapy, and they get so far, weeks and weeks and weeks. And then at some point, the therapist says, right, let's talk about that night when you were 10 years old. And suddenly, bang, they've hit a brick wall. They're out of there. They flee, they drop out of the service, they go back to the vodka, they go back to the heroin, because they just cannot go there to that place. Now, what psychedelics do, and in particular MDMA, is in combination with psychotherapy, they provide a stable, safe, and containing psychological environment for a few precious hours in which the patient, in conjunction with the therapist, in a supportive, facilitative environment, and a relationship that's very containing, can go there to that painful memory for the first time in their life. And they can go there and they can talk it through, and they can resolve, they can reflect upon it and resolve and challenge and make important realizations about themselves and their past. And they come out of that experience with a brand new way of looking at themselves and why they're in that position and what led to it. And they can do that in a way that they've not ever been able to do in traditional psychotherapy, because they hit where they would normally hit the brick wall. And so the psychedelic experience, in combination with psychotherapy, with preparation sessions and post-drug integration sessions, is a momentous peak experience. It's a turning point in people's lives. People often talk of it almost as a rebirthing experience, because it's about going back to that pre-verbal, pre-attachment time before the trauma had occurred, and rewriting, rebooting, rebranding, defragging the brain. And then, with the careful support of the therapist, you can rebuild your life again with new psychological narratives, new versions of yourself, the good, positive versions that you've always wanted and always knew were in there somewhere.
And here I have a question, because we didn't really introduce psychedelics. And there is also this notion that they are addictive. So I wonder if you could just tell something more about how we classify psychedelics, and where does it come, this idea that they are addictive?
Well, firstly, I would probably want to just say, where did you get that notion from, that they're addictive? Because you didn't read that in any medical journal.
Mm.
So this, I'm challenging you here, Alexandra, because
I'm
you're quoting
yes.
a lie to me.
Yes.
It's not true. Show me the data, please. I will show you the data to show they're not addictive. So there are some drugs that are addictive, and we know that the really dangerous drugs in our society are drugs like crack cocaine, methamphetamine, heroin, and by far the most dangerous and addictive drug of them all, alcohol, by a very, very long way. So we know that, but I'd love to see the data on MDMA psilocybin addiction, please.
There's another thing, actually, when I talk to my friends, when I said, well, I was talking about them, and I actually mentioned that there is not data that these are addictive in the same way we talk about addiction when we talk about heroin. Yet they were like, but they're psychologically addicted. I've seen people. So what do you say to that?
Well, what do we mean by psychologically addictive? Do we mean people enjoy taking them, so they take them again? Because in that case, golf and opera are psychologically addictive. We've got some very clear definitions of addiction: tolerance, withdrawal syndrome, drug-seeking behavior. these are not, the psychedelic drugs are not on the radar for drug addiction services. Find me an addiction psychiatrist that will tell you that their wards and clinics are full of people who have become addicted to MDMA and psilocybin. You don't get drug-seeking behavior with these drugs. Nobody breaks into your house to steal your TV for their next magic mushroom fix. It doesn't happen. So they're absolutely not addictive. The other bit of evidence is in animal studies, they don't demonstrate addictive behavior with the psychedelics. Drugs such as ketamine in high, frequent, regular doses in recreational use does have a higher addiction potential than the other psychedelics. But in the clinical population and the way they're used clinically, there's no evidence whatsoever that the psychedelic drugs are in any way addictive. The other bit of evidence for that is the last 15, 20 years of psychedelic studies, nobody's become addicted to MDMA or psilocybin as a result of receiving clinical doses in a clinical setting.
And now talking about the patients who actually you have treated, and I also listened to the podcast where one of your patients was a guest as well. How do you prepare, or let's talk about the study actually. So how does the study look like, and how do you prepare people for taking this in a clinical setting where we can actually help people to get better?
So we did the world's first MDMA-assisted psychotherapy study to treat an addiction. Up until then, like 99% of all the MDMA clinical research was for post-traumatic stress disorder. But I was working at the time as an adult addiction psychiatrist with a lot of cases of alcoholism. And it was quite clear that most addictions, and certainly alcohol, I consider them PTSD plus a drug. Our patients are all heavily traumatized. So we've kind of put two and two together. We knew that MDMA worked for trauma-based disorders such as PTSD. I considered alcoholism to be a trauma-based disorder. So we thought, let's put the two together and see if MDMA-assisted psychotherapy would work for alcoholism. And we carried out two studies in Bristol. The first study we carried out was an observational study with no intervention. We took a cohort, 14 people in Bristol who were heavy daytime drinkers that were undergoing detox. So they came in drinking an average of 300 units of alcohol a week. They underwent detox, which brought their alcohol use down to 0. And then they underwent 9 months of they underwent the typical treatments that you get post-detox. So AA groups, rehab, anti-craving drugs, individual therapy, group therapy, MAP groups, all kinds of supports. The very best thing that modern medicine can throw at the alcoholic post-detox. And with no intervention from our MDMA team. We just met with them regularly and collected data. And at 9 months, 76% of this group had returned to the pre-detox levels of drinking. Very sad outcome, completely what we expected. The very best treatments for alcoholism don't work very well in most people. High rates of relapse. We then took a group, 12 people in Bristol, 14 people again in Bristol, underwent the same screening in terms of inclusion and exclusion criteria, 300 units of alcohol a week, detoxed them down to 0. And then after they were detoxed to 0, they went into our 8-week MDMA-assisted psychotherapy study, which consisted of 10 sessions of psychotherapy, 2 of which were assisted with threshold dose MDMA. And the other sessions were non-drug preparation sessions. Two therapists, male-female pair, met with them throughout this whole process. And then we followed them up to 9 months, and 12% of them had relapsed to drinking, the same levels as pre-detox. Now that difference between 76% and 12% is staggering. That is a hugely positive result. These were small groups. It was a pilot study. There was no placebo group in our treatment group alongside our treatment group. The first study was they weren't randomized into these two groups. It was rather a separate observational study, but it gives us a glimpse of what you might call treatment as usual outcomes versus treatment with open label MDMA. And so that was a tremendous success. It was primarily a safety and tolerability study. And you might think it sounds a bit methodologically unsound to not have a placebo group, but you have to do, when you do a new drug in a new condition for the first time, which we were doing, you have to start with this open label safety and tolerability study. And it was very successful. And then that's led us on now to, through Awaken Life Sciences, we're developing a research program to take this study further and do a randomized control study, what we call a phase 2B study. And we're currently at the process of referring to, submitting to MHRA and ethics for that. And then the next phase will be a phase 3 study on a larger scale, and eventually seeing MDMA-assisted psychotherapy licensed as a treatment for alcohol use disorder.
And I'm also curious about the fear that people have in relation to this kind of therapy. But in general, I would say to any kind of psychotherapy, it feels like I only go to psychotherapy if I'm crazy. And then a lot of addictions, which are societally accepted, like workaholism or other stuff, are just kind of going under the radar. So having an MDMA assisted psychotherapy is another layer of fear. What will happen to me? Will I lose my mind? So I'm just wondering, how do you talk to people when you try to explain why these things actually work? Because, for example, for me, who is going through psychotherapy, it's very difficult, as you would say, it's ineffable. These experiences are yours, and it's difficult to explain them to someone who has never experienced them.
Yeah, well, I mean, you're quite right. So the patients, if I can credit the war on drugs with one very successful thing, it's its ability to poison the minds of smart, erudite people and put fear into their hearts unnecessarily. So thumbs up to the Misuse of Drugs Act and the war on drugs for doing that very successfully for the last 50 years. So indeed, people came in with a lot of trepidation about what they were to expect. And that's why with the psychedelic therapy program, there's always a lot of attention paid to mental mindset and a lot of psychoeducation around the medicine and what they'll be receiving and what it feels like. And a lot of time and effort goes into engendering a very positive relationship and a trusting relationship between the patients and the therapists, in order that when they first come to the drug session, they feel prepared and they feel confident and they know that they're in safe hands. And a lot of it is about debunking the myths that they may have heard. Like you said, you know, oh, isn't it addictive? It's like, no, it's not addictive. You've been lied to about that. Here's the truth about it. So you have to spend a lot of time building up that very positive relationship. Psychedelics are challenging. I would not downplay that they're challenging. It's almost arguable that if they're not challenging, you're not doing it right. There's that phrase from R.D. Laing, in order to break through, you have to break down. I don't think we should be saying that suffering and distress in psychotherapy is something to be encouraged, but it's something that's there anyway. And the other thing about the cohort of patients that come into psychedelic studies, these are desperate people who've tried so many other things, and they're already suffering. They're suffering every day with their trauma and their addiction. And they are brave, willing people who can see that this is innovative research, and they've had a lifelong of suffering. So the decision to come in and take part in a psychedelic research study is not too difficult for them, because they're desperate. They really want to try anything, having failed at everything else. So a lot of work has to go into making them feel reassured and safe, and it's an important part of the protocol, the preparation sessions.
And can we just also here just try to touch, how does that experience look like? And when we say psychedelic, what does that really mean?
Well, there's different forms of psychedelics and there's different forms of psychedelic therapy. And obviously drugs like LSD, psilocybin, DMT, ketamine, MDMA are all different drugs with different drug receptor profiles, different effects in the brain, and different psychological subjective experiences. I wouldn't deny that for a second. But in my opinion, we take, say, ketamine, MDMA, and psilocybin, the three most commonly used drugs in research and clinical programs. I would argue that the similarities between those three are much greater than their differences, because when they're combined in a protocol in which they're used as an agent to induce an altered state of consciousness in conjunction with their therapist, they all have the similar effect of loosening inhibitions and allowing a patient to think about their experiences in a new way in conjunction with this trusting relationship with their therapist. And going back to what we talked about before about the rigid narratives due to attachment, they give the patients for the first time in their life this opportunity to tackle those rigid narratives. So there's the patient with their head full of personal narratives. I'm useless, I'm a failure, it's all my fault. For a few precious hours under the influence of that psychedelic drug, they're not those things. Those things have been blown out the window. They're a completely blank slate. Now, that sounds kind of scary in a way, because we need our labels, we need our ego, we need our sense of self. Even if it's negative, it's kind of scary to totally lose one's sense of self. And that's why it's all about the skill of the therapists to hold that patient in that space where they feel safe for those few hours when they've lost their sense of self. Because the crucial thing is, as they come out of the therapy and the drug wears off, it's the skill of the psychotherapy to say, right, you've had those few precious hours where those awful narratives about yourself were dissolved, and now we're coming back to the real world. How many of those labels do you need to maintain? How much do you need to hold on to that old part of yourself? Or can you rebrand yourself with new narratives? And when it's done well, and when it's done properly and safely and in a skilled fashion in the right place, the patients have this tremendous ability to rewrite their past and rewrite their present and future. So it's quite beautiful to see. It's quite amazing to see. And then patients go on and continue to process their experience and make lifestyle changes, and improve and get better and overcome this aspect of themselves that they've carried around as a weight on their shoulders all of their lives.
And actually, my biggest impression from your talk and from some of the movies I watched is people loving themselves for the first time. So I'm wondering, can you share a bit of your experience about this effect that psychedelic psychotherapy can bring?
So it is this ability to self-love, because they've lost that, because it's been beaten out of them as a child. I can give an anecdote of a patient that said to me during an Mdma experience, Dr. Ben, is this love? She was lying there feeling very loved up at the height of the Mdma experience, and she said, Ben, is this what love feels like? And I kind of paused for a second, and I thought, well, hang on. This isn't love. This is a drug-induced, artificial, transient experience. She's high on MDMA. Of course she feels like this. This isn't real love. And then I paused for a second and I thought, well, hang on. She feels safe. She feels held. She feels contained. She feels trusted and trusting. She feels warm. She feels safe. And she feels in a positive relationship with these therapists that care about her. And I said to her, yeah, do you know what? This is what love feels like. This is indeed what love feels like. And it is artificial. It's been induced by a drug. It's going to wear off. But this is what it feels like. That warm, gooey, safe feeling that you're experiencing right now on MDMA is what people feel when they talk about love. And she said, wow, that's amazing. She said, I've never felt like this. My whole life, I've only felt fear and pain and anger and bitterness. And now I know what love feels like, because I've heard people talk about love, and I've sort of pretended to, when people have said, I love you, I've kind of nodded and said, oh, yes, I love you too. But she didn't mean it, because she didn't know what it felt like. So a cynic would say that's a load of rubbish. It was a drug-induced experience, not love. But if you think about it in a more psychological way, for this lady, she now has a platform on which to build what is love. So we have these very precious few hours, these privileged hours in which to induce a state which can provide then a lasting platform for her to go forward. And then after she comes down from the drug and we continue with the non-drug psychotherapy for several weeks, she hasn't lost that feeling. She doesn't have to be high again to get it. She's been there, she's glimpsed it, and has made positive changes. So this is an example really how the psychedelic experience, and similar things can happen on LSD or psilocybin or ketamine, that you have this peak experience, which is transformative and lasts. And you don't need to keep doing it again and again to get that back, because you've made the cognitive changes, you made the emotional changes, and you can then build on those and integrate them further and stay well.
Yeah, and the interesting thing for me at least is when you once feel that feeling, when someone is actually being abusive to you, you will have the ability to differentiate now, because if the only thing you have felt in your life is abuse, you will think that that is love, and that's how you will recreate these experiences again and again and again. And I just want to get to those 12% in your study that did not work. Out of curiosity, I'm just wondering, did you see or observe any correlation between what are the environments that they went back in after this experience, or do you think they needed more treatments? What do you think has happened with those people who actually went back even after the MDMA assisted psychotherapy?
Well, I think pretty much all of the patients came from very difficult, poor environments.
Mm-hmm.
And that's either because they were in that social economic status since birth, so they've always struggled and they had poor education and poor parenting and poor opportunities for employment. Or like often happens with adult addictions, you end up drifting down into that social economic status because you lose jobs and you fail to get education and you move towards that group. So all of them came from difficult environments. After their psychedelic experiences, and the reason they've been in those environments all their lives were because their narratives kept them there. I am useless. I am a failure. Life, there's no point in doing anything. Everyone's out to get me. I may as well drink. And then when they've had their curative realization experiences with MDMA, what we saw was people actively making changes to their lifestyles, people moving house, getting jobs, going back to college, because they always had those skills. They could have always done them. They just didn't believe in themselves. They didn't believe they had it in them. So successful treatment of addictions is not just about coming off the drug, whatever it is. It's about the functional changes you make afterwards. There's no point in coming off the drug and just being sober if you're just still going to sit there in this terrible position in terms of lifestyle. And I often say that to patients in normal psychotherapy. I think that functional improvements are the way to measure the success of mental disorders. Am I mentally ill? I don't know. I mean, I wouldn't judge it by my cognitive state. I've got a job. I haven't been arrested. My girlfriend likes me. My family likes me. My boss likes me. I'm financially secure. I've got a good group of friends. I don't thump people. Yeah, I'm probably mentally well. So I would measure it like that. So similarly with patients, I think, it's not just about mending your head. And I'll say this to patients. I'll say, look, I'm not going to have you here coming to me every week for psychotherapy for the next year just to turn you into an enlightened, lonely person. I don't want to fix your head. I want to fix your lifestyle. So it's what you do with all of those things. And that's where things like occupational therapy come in and are so important. And the post-session integration. It's like, okay, we fixed your head. Now, what are you going to do about it? I want to see you going out. I want to see you joining clubs and societies and visiting your children and getting a job. These things are all about healthy mental functioning. It's not just how you feel in your head, it's how you behave functionally.
And you mentioned we will come back to the curative. I'm just wondering if that what you have just mentioned relates to how we cure mental disorders.
Well, yeah, I mean, the C word, cure, it's with this what we talked about earlier, this predominantly top-down biological model using these daily maintenance drugs like SSRIs, mood stabilizers, hypnotics, which you take every day, day in, day out, for weeks, months, years, decades, just to suppress symptoms but not get better. It's like if you break your leg, and instead of getting surgery and having it fixed with an intensive, one-off, expensive piece of intervention, surgical operation from the orthopedic surgeon, instead of that, you just tank yourself up on painkillers and hobble around on a broken leg for the rest of your life in maintenance therapy with analgesic drugs. Now, nobody does that. That's a crazy way to do medicine, but that's what we do with psychotherapy. That's what we do in psychiatry. We don't fix the cause. We instead leave them with this broken leg and fill them full of painkillers, the psychiatric drugs. So the cure word is a word that we've lost sight of in psychiatry. A lot of psychiatrists behave almost as if they're palliative care doctors. They just get alongside their patient for life. And the sad thing is, if you're going into your psychiatrist at the age of 20 or 30 with a severe anxiety-based disorder such as PTSD or addictions, for the first time in your 20s due to severe child abuse, you're probably going to be seeing that psychiatrist in your 60s and 70s after a lifetime of drugs, being maintenance drug therapy. And that's not good enough. And I'm really driven by that. I believe that, we've had modern psychiatry for 100 years now, and our outcome rates are very poor, and we can do better. And what the psychedelic-assisted psychotherapies offer, they're the surgery. They are not maintenance therapy. They're not just, let's patch you up and keep having you come back for the rest of your life. They are the surgical operation. It is the orthopedic surgery of psychiatry. We get you in, we do an intensive piece of work that is expensive in terms of time management and the facilities, and it's difficult, like surgery, and you need to be very careful in the way you do it, but then you are better, and you are fixed, and you are cured, and I dare say that word, and goodbye. We don't need to see you again. You're discharged. You don't need any medications anymore. The broken leg is mended. So all these analogies, I broke my legs when I was 15. I underwent a lot of painful, intensive treatments, but I was discharged at 17 and never went back. That's how we can treat mental disorder with the psychedelic-assisted psychotherapies.
Wow, I really admire your optimism, and actually being in those experiences, I do believe your optimism, which is just incredible. So being mindful of the time, I would just go to the rapid fire questions, although I would love to ask many more. So one of them is, what is an absurd thing about you that not many people know about?
What a bizarre question. An absurd thing.
Mm-hmm.
I'm going to make it harder for you. Can you define absurd?
Absurd. So something out of ordinary that is like almost an outlier in terms of what we observe in everyday life.
I suppose an absurd thing. I suppose the whole thing about the psychedelics is that I present myself to my profession as a very straight, sober, evidence-based, scientific, conservative type person, because I believe that's really important in order to communicate in the correct language and get things done and get these approvals over the line. But at heart, I'm very much a hippie and a raver.
Actually, that's very much coming through when I see you. And then what kind of compliments, if any, do you like to receive?
Well, by far the greatest compliment I could possibly receive would be from a patient who tells me that they have got better and that they have seen the majesty and beauty and efficacy of psychedelic drug treatments. And when I hear patients say that, which I do, I've been alcoholic for 30 years. I've been heroin addicted for 30 years. I've been in hospital. I've self-harmed. I've attempted suicide. I've been on every psychiatric drug under the sun. And then I found this treatment. And for the first time in my life, I feel like I can be the person I want to be. I wish I'd done this years ago. I wish it existed. Thank you so much for helping me to be the person I want to be. That's by far the greatest compliment I could possibly imagine.
Wow. And actually this brought me to ask you one more question around this topic. Did you, because we talked that the trauma is at the core, and I'm just wondering, did you see that psychedelic therapy works better for one in comparison to other, let's say, personality disorders or addictions? Or I already expect the answer, but I'm just curious if you have seen someone who's, let's say, borderline, and you say psychedelics not really good for borderline.
I mean, I think we're still in the infancy of understanding how best to apply different psychedelics to different treatments and different treatment protocols for different psychiatric indications. But going back to what I said earlier, you know, it's my belief that all of these different diagnoses are all a load of rubbish anyway.
Yeah.
And they're all the same thing. So certainly, I wouldn't be saying all psychedelics work for all patients all the time, first time. That would be disingenuous to say that. But I do believe that we're moving towards a day where we will be less restrictive about psychiatric diagnoses and which psychedelics. So I think we're going to be 5, 10, 15 years from now, you're going to be able to go into your psychiatrist and you'll be able to have, whatever your psychiatric diagnosis, you're going to have a whole range of different psychedelics to choose from, which will be combined with psychotherapy. One way of looking at it is if you take any psychiatric disorder that responds in any way to psychotherapy, which is every psychiatric disorder, because we use psychotherapy for everything, whether it's depression, anxiety, even schizophrenia, psychosis, personality disorders, whatever you name it, addictions, all of them have some form of psychotherapy that works partially. It's my belief that psychedelic assisted psychotherapy will work even better. So at the moment, we're kind of pigeonholing certain people into certain groups, but I think it's all going to be available and open to everyone in due course.
Well, I do hope so. And the last question, what are things that you have become more, and what are things which have become less important as you have gotten older?
For me?
Mm-hmm.
I don't think anything's changed for me.
Mm-hmm.
My core principles are the same. My general rule for life is, number 1, be kind. Number 2, be happy. And number 3,
Wow.
don't get caught.
Wow.
So, you know, I think we know when we're being kind. We know when we're not being kind. So those basic principles that were taught to me with my childhood, which was very warm and loving and nurturing, have always persisted. And I don't think those have changed. You know, all sorts of material changes happen as you get older, and suddenly it's all about mortgages and things like that. And, you know, obviously the core principles have remained the same: to care for my friends and my family and see them happy, and compromise my own happiness at times if I need to, in order to put their needs above mine. But not to an extent that I cannot continue to personally grow and develop. You know, we haven't got long. We've got what, 86.4 years or whatever, and then that's it, and you're eaten by worms. There's no God, there's no afterlife. This isn't a dress rehearsal. This is it. We will never get this hour back, Alexandra. That's done. The clock is ticking. Get on with it. Don't waste time. Pay attention. Care for people. Be lovely. Have fun.
I'm actually happy that I have spent this hour in this way. So thank you very much. I actually really applaud you, applaud your kindness, I applaud your courage to actually do this work, and actually curiosity, because I think it's all led by it. So thank you very much.
Brilliant. Well, thank you very much too. It's been a great pleasure doing this.
You have just heard the story of Dr. Ben Sessa. Dr. Sessa Jones' interest in psychotherapy, pharmacology, and trauma have led him towards researching the subject of drug-assisted psychotherapy using psychedelic adjuncts. In the last 15 years, he has been part of scientific and clinical studies administering LSD, psilocybin, ketamine, Mdma, and DMT to patients and volunteers. He is also an author of psychedelic medical exploration book, notably The Psychedelic Renaissance. And alongside Professor David Nutt, he has also been a long-term advocate of drug policy reform in the UK. You can connect to Dr. Sessa on his webpage, www.drsessa.com, or you can find him on Twitter @Ben Sessa. Thank you for joining me for this episode, and I hope you will come along